Right, thanks very much. Zoe asked us to come today to talk a bit about what dietitians do. She said that not everybody kind of knows what we're doing, so hopefully I'll make that a little bit clearer today. So we'll cover a bit about what we do, a bit about nutritional assessment, a bit about nutritional requirements. So some of this has been covered in some of the presentations that you've had from Dr. Scott, but I'm going to talk more about the practical application of that and give you some case studies along the way as well. So there's 7 of us in total across the 3 sites, but with one person on career break currently, but that equates to 4.4 whole-time equivalent. So most of us work part-time. And what a dietitian is, we sort of translate science into the practical application of nutrition therapy. So what we do then really, I think when I went into dietetics, a lot of people thought that I was going to come out with some sort of health guru and force fruit and vegetables onto people, being a real fitness fanatic. But actually, it's not like that at all. Society seems to think when they hear the word dietitian, these connotations that we're going to steal their puddings off them or something. So we've been out for Christmas do's in the past, and when they say, "Oh, we're a table of dietitians," people start booing us because I think they think we're going to try and ruin the party and take the drinks away from them. And actually, when I used to do clinics, patients used to be quite scared of coming to see the dietitian. Thought we're really going to tell them off for everything that they did. And one of my first jobs, so years ago before I worked in critical care, when I was sort of ward based, I think people think that you're like the food keepers, really. Of people used to refer patients to us to get a fruit corner yogurt, like we're the gatekeepers to the catering budget. But actually, on critical care, I do far more sort of writing calculations, and you'll see us at the bed ends for quite some time, doing lots of different calculations. So there's far more writing and calculations and maths than I ever thought there would be in dietetics. So what we do nutritional assess nutritional status. We assess nutritional requirements for energy, protein, and fluid. We try and influence the feeding route. We provide feeding plans for enteral nutrition. We can order and prescribe PN. So we've got 3 non-medical prescribing dietitians within the team, and another on currently doing the training. And we do lots of audits and training, and we're doing the mandatory training for nurses this year. And then we also sort out things in the background like the enteral feeding contracts, and we do data gathering for cost improvement projects as well. But I think we like to think that we influence people, and you'll see us peering at you in ward rounds to see where you're going next. Because although we haven't got time to come into the full ward rounds, we are watching where you're going and trying to appear at the appropriate times. So I think we do look a little bit like this. So information gather, obviously particularly looking at nutritional assessment. So your weight, your height, and your BMI and percentage weight loss. And then number of days without nutrition. And it doesn't take long in a hospital world for days of patients not eating to go by. If you're being conservatively managed, if you've come in with an ileus, for example, 10 days can easily go past and it turns out you've not had any nutrition. And patients may have had poor nutrition before they've come in if they've been poorly for some time. So we look at what's happening in that time frame, but also we look at the same information that you all look at on the charts. So all the information on the charts, all of the information on the drug charts and interactions, all the trends, all the bloods, all what's happening with the kidneys and the bowels. So it does take us quite a long time to gather all the information. So looking at nutritional assessment in a bit more detail. So the MUS tool is not the best tool for assessing nutritional status on our critical care patients, but it is the only one that we use, and it gives us a bit of an idea of what's happening. So if we look at BMI, so less than 18.5, the likelihood of having a poor energy nutritional status is quite high. But it does depend on your patient population, and it is different for different genetic groups. So for example, a few years ago, I went to China on holiday, and at that time my BMI was 22 and I would wear a clothes size small. So I went to China, and we were sort of in a clothes store, and the lady brought out for me size extra extra large. So in a different population than I was being described with a BMI as being obese. And the other people in the group, so average BMI in this country is about 28 when you get to my age. They were told there was nothing there for them, nothing would fit them at all in that store. So I think it's just quite interesting to bear in mind that although if you've got a BMI of less than 18.5, it's likely that you've got poor nutritional status. It's not true of all populations, and you could be quite healthy and eat quite well at that. So BMI 20 to 25, it's unlikely that you've got poor nutritional status. However, if you look at that in context with weight loss, it could happen that you've lost a lot of weight and still have a BMI of 20 to 25 or even higher. And quite often the patients that are well nourished and obese or high BMI, if they've lost a lot of weight, they get missed. Because they look like their nutritional status should be okay. So we always look at BMI along with percentage weight loss. So a weight loss of 0 to 4% is considered a sort of normal fluctuation in weight. 5% is an early indicator of undernutrition, and particularly if it's rapidly, and greater than 10% is clinically significant. And we do see patients quite regularly on critical care that have, lost 15 to 20% of the body weight. And then we would also bear in mind how many days have they not had nutrition. And like I say, that can fly by in the hospital setting. We're obviously limited by the information that is available to us. So these are actual heights on an actual grown-up on LRI ITU fairly recently. So she was somewhere between 1.22 meters and 1.59 meters. So her BMI was somewhere between 11.9 and 20.2. So obviously, if the information is not accurate, it's very difficult to do assessments properly. I think in the end, we'd worked out our height was about 1.44 meters. So she was very undernourished. She had a BMI of 14, but it wasn't as bad as a BMI of 11, and she certainly wasn't in the normal BMI range. So visually, we have to check that the information is accurate, but it can be really difficult on critical care when you can't talk to your patients and you can't measure heights accurately either. So energy requirements, they do vary between all of us. So just like your house, obviously there's a lot in the news about how much energy your house needs, how much is it going to cost, which is obviously affected by size and insulation and fuel source and everything. So your energy in people is exactly the same, affected by gender, weight, height, clinical condition, the temperature of patient, route of feeding, duration, rehab goals, physical activity, wounds, etc. So we're there to monitor and refine goals. So in any paper that you read as to how we should measure our energy requirements of our patients, the gold standard is using indirect calorimetry. So it's recommended by the American Association of Parenteral Nutrition and the European Society of Parenteral and Enteral Nutrition, and also the Dieticians nutrition group, which is PENG. So most people would say that you need to have these. Now, they're not widely available in the UK yet, but they are becoming more common. So they used to cost £40,000 for one of these, but now the cost is significantly reduced. And this is what we would really like to start using on critical care if somebody would give us some money. So currently the cost is about £17,000. This is what it looks like. So this is telling us that this lady's here has got energy requirements of 1,575 calories. Now, obviously, she doesn't quite represent her critical care patients. There's a bit less tubes and wires than you would normally see. But you can have set attachments that attach to the ventilators and tracheostomies, or you can have this hood that we see here. So they're useful for different types of patients. And what it does is it measures pulmonary gas exchange and then provides an estimation of oxygen and carbon dioxide production. Then there's equations that they use in the background within the machine, and that tells us what the predicted energy requirements are. And it's useful for patients that are longer stay critical care patients. for more than 5 days. It takes probably about an hour of time by the time you set it up, although you're only measuring for a few minutes. So you won't be doing it on everybody, but units comparable to our units here in Leicester would probably do this on about 5 patients per week. But we don't have one of those. So what we do use are predictive equations, but again, they're not perfect. So the evidence for our predictive equations comes from this paper of Frankenfield in 2009, where they reviewed 7 prediction equations against indirect calorimetry. Now, like a lot of things on critical care, they excluded the sickest patients, but they did find that the most accurate equations were the Penn State equations, which are the ones that we use. And they were accurate, and 67% of patients found that there was less than 10% of difference between measured calories and predicted calories from the equations. So that is why we use the Penn State equations here. The accuracy did diminish as patients got BMI increased or decreased. And the equations that we used to use, the Schofield equations, they correlated poorly, so we've stopped using those a few years ago. So the disadvantages of using these, they require average minute volume, so we can't use them on CPAP patients, and the evidence for ECMO patients isn't there because they've got unreliable minute volumes. They're a bit long-winded, but we have obviously got these programmed into calculators for us, and you can see the things in bold there are the things that are variables. So gender, weight, and height and age is the first part of the equation, and then the second part of the equation takes the MSJ part, which is the Mifflin-St. John equation, and then adds in the factors specific to critical care, like the maximum temperature of the patient in the last 24 hours and the current minute volume. And now, obviously, this can change quite rapidly, so we review these regularly. And as you can see from the calculation of the temperature, so it's temperature in 24 hours times 167, having a 2 or 3 degree difference in a patient's temperature might make 500 calories difference to their energy requirements, so over a couple of days. So we're always looking to see what changes are in the clinical picture of the patient to see if what we've calculated is still valid. And in the absence of minute volumes, we would use calories per kilo, but the advantage is it's simple, but it's probably a bit too simple because it's assuming that everybody's got the same amount of lean body mass and same muscle mass. This is recommended again by the European Society of Parenteral and Enteral Nutrition at 20 to 25 calories per kilo, and the American Society as well, about 25 calories per kilo. But it's not suitable for obese patients, so we use the MSJ equations for them, or Aspen recommend 11 to 14 calories per kilo. So we've got lots of options, and we tend to work out a bit of a range to see what can work practically. So we use a clinical judgment on this. But if you're giving a lower calorie per kilo, for example, 11 calories per kilo, then it's really important that you're given adequate protein to preserve lean body mass in these patients. So the other question is, should you then feed to your predicted requirements, which is obviously controversial, and we don't know exactly what we should be doing. So if you feed too much, it can lead to problems weaning off the ventilator, so hypercapnia, high blood sugars, refeeding syndrome, problems with your liver, high triglycerides, and acute kidney injury. But also associated with poor outcomes is underfeeding and weaning difficulties and muscle loss. So current advice is that we don't need to feed above 80% of predicted energy requirements, and some studies would show a benefit from underfeeding. So it's important to get it right, and that's obviously why you've got a dietitian on the unit. So we don't purposely target less than our requirements. And the reason for this is when we've audited it in the past, so this is our 2016 UHL audit data, at this time we were aiming to eat 85% of our protein and energy targets. And actually what we found was we were only meeting 67% of our targets for energy and 62% of protein. So we felt that if we purposely aim for less, then we're just going to deliver even less than the target. So we aim for the full amount and assume that they're not going to quite meet that. And the reason they don't always meet that, so again, this is from the same audit in 2016, This is looking at the stoppages on critical care and when they occurred. So this is the number of stoppages up this side, and this is the ITU day. So obviously we had more people in the first part of the first few days were being fed, and it did tailor off. But we did find the stoppages were predominantly in the first 6 days. So due to things like trachees and scans and weaning patients, the feed was being stopped. I do think things have changed since 2016 with how often we stop the feeds. We often don't stop them until they're just about to go somewhere and we drain the stomach. So I think when we repeat this audit, it might look slightly different. But that's what we've based our feeding plans on, that we know that they're not going to get the full delivery. So if we look at a case study for energy requirements, so this is a 45-year-old man who was at the Royal recently. He came in with flu and he was ventilated for approximately 40 days. He came in with, he had multiple organ failure, so respiratory as well as acute kidney injury, and he was on the filter for most of his time here. When he came in, he was 88 kilos and his BMI was 28.7, and we frequently recalculated his energy requirements. So a lot of data on that slide there with all the times that we've recalculated his energy requirements, but they've worked out somewhere between a minimum of 1,680 calories and 2,300 calories was the maximum. And protein requirements, depending when he was on the filter and what his weight was at the time, was somewhere between 67 grams of protein when he was off the filter at the very end, and up to 142 grams of protein. So you can see there's huge variations in the protein requirements of this gentleman. So he came in and he was 88 kilos. He was too poorly to be weighed for quite some time. So when he was weighed, he was 67 kilos, so he'd lost 24% of his body weight in that time. And his grip strength, when we were able to measure it, was 15.8 kilos, which is approximately 25% of the average. So for somebody of his age, you would expect a grip strength of around 50 kilos. And his was 15, but that's not unusual for an ITU patient to have such low grip strength. Quite often it's in the single figures when we start to measure it. So if we've got somebody that's on ITU for 50 days, hypothetically, if we were feeding 300 calories under his estimated requirements, because we were using a predictive equation that's accurate in 67% of the population studies within 10%, even if he was one of the 67% of patients, we could be underfeeding him 300 calories a day, which in 50 days equates to 15,000 calories. So that's 15,000 calories that we're not even attempting to give this chap because we didn't know that he needed it. So in a well patient, that 15,000 calories would be the equivalent of a 2 kilogram weight loss from this calorie deficit, but possibly even more in somebody who's hypermetabolic and he's muscle wasting and he's critically ill. So this patient lost 24% of his body weight and he left ITU with a grip strength of a 10-year-old. So if we had used indirect calorimetry, would we have been able to have prevent some of the weight loss? Definitely not all. That is impossible. We don't even aim to do that. But maybe he would have left ITU with 18% body weight loss and a couple of kilos stronger of grip strength. So we don't know that, but that's kind of the benefits of having the indirect calorimetry, that you can be reassured that you're giving people the right amount. So talking about protein requirements, so hypercatabolism and hypermetabolism lead to high levels of muscle wastage. And if you've seen ITU patients for a long time in ITU, they do waste away in front of you. It's quite scary how rapidly the muscles can waste away. So they can lose 1 to 2% of muscle per day. But it's unknown whether we should try and match the protein losses or how much to give. Evidence suggests that high protein is associated with reduced mortality, but you require the adequate energy provision. And there's probably going to be a lot more things coming out in the future about individual amino acids. So we've been through these in the early 90s with things like glutamine. At the minute, they've got a particular interest in leucine. So it's likely that there'll be more targeted amino acid supplements for our critical care patients in the future. So protein requirements, it depends on your BMI. So current recommendations from European Society of Parenteral and Enteral Nutrition is 1.3 to 1.5 grams of protein per day. but if they're on renal replacement therapy, 1.5 to 1.7. But if you're in acute kidney disease or chronic kidney disease, then just 1 gram of protein per kilo. So things vary as to whether people are on or off the filter, which is obviously really important for us to be keeping an eye on what you're doing, which is why we sometimes ask what you're doing with the filters over the weekend, so that we can put in the appropriate plans. If they've got a high BMI of over 30, then there's a varied range from 1.3 grams of protein per kilo ideal body weight to 1.3 grams of protein actual body weight, which is obviously a huge difference. And the American Society recommends maybe 2 grams of protein per day of ideal body weight if the BMI is 30 to 40, and 2.5 if it's greater than 40. So again, we work out a range and work out what's practical. And again, these are predicted losses, but are these the same as requirements? We don't know, but this paper came out this year, which is what we were waiting for, which was the EFFORT trial, which looked at high dosing of protein in our critically ill patients. So it was a multi-center registry-based randomized trial. So there is 1,300 patients in these sort of final calculations, but actually they didn't find that higher protein was good. What they found was it was acceptable to prescribe the lower end of the recommendations of 1.2 to 1.3 grams of protein per kilo, and it suggested that international guidelines review the recommendations for your obese patients because they were too high, and possibly that the high protein doses worsen outcomes, particularly leading to acute kidney injury and multi-organ failure. So I think we're going to continue to aim for the lower side, which is handy because we can't always meet the really high protein requirements that was previously calculated anyway. Then we need to consider other sources of energy. So propofol, you're probably all familiar, it's got 1 calorie per mil, but so occasionally you get patients that are on 40 mils an hour propofol, so you're getting nearly 1,000 calories just from a bit of lipid. We also consider the citrate calories from the filters, so it's got 0.59 calories per millimole, and then obviously you've got your dextrose, which may have 200 calories in a litre, it may have 400, it might have 800 calories depending on the strength. So all of these things are obviously taken into account, hence we've got our calculators out again. So I just wanted to talk through a case study on nutritional requirements. So this is a lady, 70-year-old lady. She came in with a pressure, grade 4 pressure ulcer, and she was diagnosed with necrotizing fasciitis, and she was having regular debridements and washouts of her sacral sore, and a past medical history of significance was chronic kidney disease. And her weight was 76 kilos and her BMI was 26. So we estimated her requirements. So we used the Penn State equation because that's what we do. And that worked out is 1,370 calories. So just thinking about what you might read on a box of cereal, for example, is the average woman needs 2,000 calories and the average man needs 2,500. Obviously, this is significantly less that our people on ITU are requiring. So that's what we were aiming for. However, you were given 360 calories of propofol, and you were also given 382 calories in citrate, and you're also given 384 calories from glucose. So before we'd even seen this lady, there was only 244 calories left to find in terms of energy for the feed. We worked out her protein. So when she was on the filter, she needed 130 grams of protein. But if she was off the filter, 76 grams of protein. But she did have competing factors. So we felt quite comfortable giving the high amount of protein when she was on the filter. But then it's a bit more tricky when you're in AKI, but you've got a large wound, as to get the best amount of protein without pushing somebody back into acute kidney injury. So what we would do is provide the best plan that we can. We would probably negotiate a little bit, ask you what you're doing with your propofol, and sort of work things out from there. So if she'd been on a standard protocol feed, which would be like 40 mils an hour of protein plus, and then all those nutritional energy, she would be getting 2,600 calories, which is 1,200 calories more than she would have required, plus 45 grams of protein less. So we switched her on to Nutrizon Protein Intense. We did have to overfeed her because it would be, with all the non-nutritional sources, it would be difficult to get enough protein in. But that's kind of the balance that we struck with this lady. So we then devise a feeding plan. So our feeding regimes look like this. So we often do a couple of feeding plans for patients. So this one's Nutrizon Protein and Plus, sorry, Protein Intense while she's on the filter, and Nutrizon Concentrated when she comes off the filter. So we can do so we're prepared for, you know, that bit of weaning off. We also, but it is useful for you to look at the feeding plans because it tells you how much carbohydrates on there. So sometimes that might be quite useful for you to look at if patients are on insulin. And also we also tell you what the sodium, potassium, and phosphate content of the feed is as well. So it is useful for you to look at this information. I don't know if you all know it's there because I see sometimes people looking at the bottles of feed to get this information, but we've already done the calculations for you. We've got a huge range of enteral feeds within UHL. So your most common one that we would have on critical care, Protein Plus, it does work out that it fits a lot of our patients' requirements really, really well. And now we're much happier that we've got Nutrizon Protein Intense. So in a litre of Protein Plus, there's 1,250 calories and 63 grams of protein. And in a litre of Protein Intense, there's the same calories but 100 grams of protein. So it's been a really good way of meeting the protein deficit in our patients without using supplements like ProSource. We've also got concentrated feeds. So these are 2 calorie per ml. So they're ideal for renal patients that need low volume, but they're also lower in electrolytes and slightly lower in protein as well. And we've got peptide type feeds as well, like Nutrizon peptide, high energy, high protein, and Peptamen HN as well. So we've got a variety of things to choose from. That's part of the enteral feeding contract. We've also got fibre versions of all the feeds as well. So we've got a lot to choose from, but it probably does look a lot of the time that the patients are on Protein Plus, but that is how it often fits. So we've got a standard enteral feeding guideline, and this is what you're supposed to follow when you are prescribing the enteral feeding on the drug chart when they've not seen a dietitian before. So you are supposed to check if a patient has got any allergies. So Protein Plus contains fish oils and pea protein and milk. So if they've got any of those sorts of intolerances or allergies, then you need to prescribe a different feed, and on the flow chart it will point you in the direction of Nutrizon soya. Obviously, if they've got a soya allergy, then that wouldn't be appropriate, so follow the flow chart from that. If they do have a soya and milk allergy, that can be a little bit more tricky. So we had a patient recently who we ended up having to put onto elemental feed, which was a powder made up with water decanted into plastic containers, feeding via JEG tube. So that is not an ideal scenario. But you do need to check because we do have incidents where people have been prescribed Protein Plus and they've got a fish allergy. And then this flowchart here, which you probably can't see at all very well, it talks about the maximum rate of feed to prescribe. So it's 50 mils an hour is the maximum to prescribe if they're over 50 kilos, or 40 mils an hour if they're under 50 kilos. But please use your discretion. If you think they're on really high doses of propofol, using lower amounts would be absolutely fine. We've tried to keep this flowchart straightforward with not putting in too many eventualities, because actually it's so difficult to predict on critical care. So we're able to see the patients usually fairly quickly once they've been admitted to ITU. So usually they're on this for no longer than a couple of days. I then just want to talk about tolerating. What does tolerating feed mean? Because we use that word quite a lot in critical care. Obviously your patients are sedated, they can't tell you how they're feeling, so we're relying purely on the clinical signs, and whether the abdomen is distended, whether we're measuring abdominal pressures, are they more than 15, what is the trend with this, what's happening with the bowels or stoma, but we put quite a lot of focus on these gastric residual volumes. What is the trend and what is the volume? So just to give you a bit of a picture of what gastric residual volumes is obviously all about. So you may have 4.5 litres a day plus enteral feed passing through your stomach. Now this picture of the NG tube, the tube's in a really nice place, but even in this, it's not going to completely drain the stomach. But you may have a tube that looks a bit like this. So yes, it's in the stomach. Yes, it might be safe to feed, but you're not going to drain anything out of that at all. On these two tubes, you might both be draining 15 or 50 mils out of them. But obviously, one of these is more likely to vomit than the other. So I guess a debate to open for another day is, should we measure gastric residual volumes in all our patients? Some units would only measure them on like surgical patients, for example. We measure them on everybody. But if we only did them on patients like ECMO and cardiac surgery and GI surgery patients, for example, maybe it could be done a bit more thoroughly and people would try and get aspirates a bit better. And I guess my question is, do gastric volumes lead us into a false sense of security about how well a patient may be tolerating their enteral feed? So I've got a case study to demonstrate this point. So this is a lady, she had a Hartmann's procedure for peritonitis. She had a BMI of 31, but she was quite nutritionally compromised with 3 weeks of minimal nutrition preoperatively. We started NG feeding, she had low gastric volumes, she was in high doses of noradrenaline, stoma wasn't active, and she was pretty unwell with a temperature of 39. By day 4, she still had a dusky stoma, still had abdominal concerns, but we were still able to feed 30 mils an hour because she had low gastric volumes. Day 6, stoma was still not active. Gastric volumes were about 2 to 250 mils. There was a CT scan requested because there were a bit concerned about her abdomen, and there was solid feces throughout her abdomen. But we were able to feed 50 mils an hour of NG feed and try and work on the bottom end and give her enemas and resolve the constipation. By day 7, she was vomiting, but she still had low gastric volumes and still had an inactive stoma. And by day 8, I was getting a little bit fed up, if I'm honest. And there was an experienced nurse supervising another nurse at the bedside. And I said, there's no way that she's got zero gastric volumes. It's getting a bit crazy now. She's vomiting, but she's on full feed, and nothing is coming out of the stoma. So then I watched her trying to gain gastric aspirate, and with a lot of patience and getting rid of the air and keeping going back to it, she got 600 mils come out of dark brown fluid, and then the same happened later on in the afternoon. So it's possible that in this lady we might have started PN sooner if we weren't so reliant on the gastric volumes in this patient. But 11 days later, or 11 days post-op, her stoma was working with enemas and laxatives. So it took a while, but obviously she was nutritionally compromised from the start. So there was a bit of an over-reliance there really on gastric volumes. So I just urge you to sort of consider the clinical context of gastric volumes. So gastric volumes is the amount that can be aspirated, not the amount in the stomach. And it does depend on tube length, tube size, tube position, experience of the nurse, and maybe how motivated they are to aspirate the tube as well. So if you're having to aspirate the tubes on all the patients on critical care, a lot of the time we're not really bothered if they only get 15 mils out in a medical patient with a soft abdomen and working bowels, but we are very more concerned with a distended abdomen. So this probably could come across a little bit better to the nurses, and we've added this into the mandatory training for the nurses as well. I'm going to talk a little bit about refeeding syndrome. So I know you know what all this is. This is David Blaine here, who did an experiment in 2004 where he sat in a plastic box above London for 30 days, and they monitored him for refeeding syndrome when he came out, and he did develop refeeding syndrome. But I know we all know about refeeding syndrome, but people still ask, does it exist? Are we a bit too cautious about it? What are the problems now? So you may have seen a very similar slide to this. Certainly, Dr. Scott's got a very similar one in his presentation. So you're in a starved state, and then the problems, and your body's breaking down. It's sort of muscle and fat stores, and the problems happen when you start to refeed, particularly with a carbohydrate source. It stimulates the production of insulin, and then it suddenly shifts everything into the cells. So you've got an increase in glucose in your cell, an increase in thiamine, increase in potassium, magnesium, and phosphate, which extracellularly can lead to, low levels of magnesium, potassium, and phosphate. So things plummeting really, and that's the kind of basis of the refeeding syndrome. So my first experience of refeeding syndrome was when I didn't know anything about refeeding syndrome, and this is my first job in 1997. So I can't believe that I'm old enough to talk about history like this. But although it was people knew about refeeding syndrome after the war, and papers in the early 90s started talking about the management of refeeding syndrome. In 1997, the word had not really got out there because I'd already completed 4 years in university and not heard about refeeding syndrome. I'd been on clinical placement and not a single dietitian had mentioned refeeding syndrome. So it just wasn't, the word wasn't there. So it's not a case study. This is a recollection of events because I didn't actually realise how significant this patient would be to me. So he was in his 60s, he was widowed, he'd been neglecting himself after his wife had died. His BMI was around 13, and I do remember thinking he's one of the skinniest people I've ever seen in my life at that point. But a very well skinny person. He was mobilising, he was reading, he was sitting up reading the paper, he was walking around the ward, he was very, very well. So we started NG feeding as normal. So at that time, NG feeding as normal was you just start the feed and you don't even check any of the bloods and you don't give any vitamins. So we didn't know about it. Now, when I went back to check him on the next day, I had found out that he died within hours of a cardiac arrest after starting the feed. So I was a bit shocked by this, and I said to one of my senior colleagues that this had happened, and we started the feed, and then he died, and didn't know what had happened. And she said to me, "Yeah, that seems to happen a lot." So there was still no mention of refeeding syndrome at all at that point. And it wasn't until a couple of years later when we started, it became a lot more awareness in hospitals, and the parental and enteral nutrition group did a lot more promotion about it. Dietitians got trained, and then we spread the word. So I just want to talk about this case study on refeeding syndrome because it was slightly different. So this was in 2005. Now, at this point, I had just written the guidelines for refeeding syndrome for the trust. So they came out around 2005, and the NICE guidance for refeeding syndrome came out in 2006. So we were presenting this at one of the doctors' meetings for the medical team. So the person that presented this case study was Dr. Jess Williams, who was one of the gastroenterologists. So she talked about this lady who was 30 years old with Crohn's disease. She lost 33% of her body weight, and her BMI was 13. Her weight was 35 kilos. She was referred for NG feeding, and she was identified as very high risk of refeeding syndrome. So this was our pre-feeding blood. So our phosphate was 2.84 pre-feeding. By day 3, it was 1.12, and by day 4, it was 0.87. We started feeding at 10 mils an hour, and we built it up really, really slowly, and we gave her all the B vitamins, and we were doing everything that we should be. So you might be looking at those bloods thinking, well, that's not very interesting because the phosphate was high and now it's normal on day 4. Or you might be thinking, that's quite a rapid drop quite quickly, and we are talking about refeeding syndrome, so maybe I should monitor those. So what actually happened was she didn't have her bloods checked again until day 7. And that's when she had a cardiac arrest. She had a cycle of CPR. She was intubated and transferred to ITU. Her phosphate was 0.1. Her magnesium was 0.4. And sadly, she died. And the feeling from a gastroenterologist was this was refeeding syndrome. So I think this is really just to highlight not getting complacent when things appear to still be in the normal range. So though this is unlikely to happen on ITU, it may happen when patients are then transferred to the ward who are still monitoring for refeeding syndrome, and we just need to have really careful handover of those patients. We will hand them over to the dietitians as well, but obviously we're not here at weekends, and we're not the ones that are doing the blood checks, get the requests. There is a guideline for refeeding medications within the trust. So our guideline is 100 milligrams BD of thiamine and vitamin B co-strong, 1 tablet TDS, and forceable soluble. We can give Pabrinex, and we do give Pabrinex, but this is just to note that some months we spend over £1,000 on Pabrinex on critical care. So from a cost-effective point of view, if patients' guts are working, then the enteral route is absolutely fine for these. There's various recommendations of different amounts of vitamin B, and whether IV or enteral within national guidance, but our UHL we've decided to go for this one, so just be aware of that. There is a slight risk of anaphylaxis with Pabrinex as well, and I think we did have a patient over the last couple of years ago that had an anaphylactic reaction to it, although the incidence is very low and it shouldn't put you off prescribing Pabrinex. So I put the meerkats back up again because I realised I was a bit depressing with my case studies at the end, so I thought I'd try and make it a little bit more lighthearted. But just to sort of finally say, just use your dietitian as a source of expertise, use enteral visins where possible, think about what you're prescribing in terms of non-nutritional sources, because that can have a huge impact on energy requirements when we're trying not to overfeed a patient. Consider gastric volumes within the context of the patient. And if anybody wants to ask me anything, then that would be great. I haven't talked about PM because there were so many things that I could talk about. It was just going to go on for a bit too long. So I'm happy to come back another time if Zoe wants me to do any further updates on that. But it was just getting a bit too messy and too much information there. So thank you. I can see some clapping there. Thank you.
Thanks, Maura.
I'll take a bow.
Did anybody have any questions?
Moira, just quick, totally off subject, but is there much in the world of dietitians talking about the microbiome and that in critical care?
Yes, well, it's quite interesting topics, isn't it? So yeah, a couple of years ago when I was at a conference, we were talking about the gut microbiome, and it's all healthy but guts, and using fecal transplants and stuff as well. All that kind of information was coming out. So there's nothing current that we're looking at, but you know, I'm a big believer in things like, you know, probiotics and gut health, and we're stripping the gut with all our antibiotics. And yeah, if I was on antibiotics, I would be taking probiotics at home, but obviously things like that are quite difficult in the ITU setting with the infection prevention and stuff, plus obviously the dosages that you need to do. So yeah, it's definitely an interesting area.
Thanks, Maura. You're more than welcome to come back and talk about TNS and trade, that's fine.
Okay, lovely. All right, thanks very much. Okay, bye.
I'm Zara. I'm one of the anaesthetic CT3s at Glenfield at the moment, and I was asked to do a quick 10-minute presentation on Journal Club for to go along with the presentation from Moira. The aim of the Journal Club really is to look at the question that the paper is trying to find out about, what its findings were, and then we're going to look a little bit on how practice has changed because of it, and whether that whether it impacts UHL policy or not. So the paper that I've been asked to look at is a paper that was published to do with the effect of higher protein dosing in critically ill patients, particularly with a high nutritional risk, and this is based around the EFFORT protein trial. This particular publication was published on January 25th, 2023, as you can see, and it was, I'll talk a little bit more about the actual ins and outs of the trial, but it was run from November 2017 until December 2021. So, fine. So the question that the trial is asking is essentially there's not much data around for what protein dosage is best for patients in the critical care scenario. So the International Critical Care Guidelines recommend a range of protein dosage, which can be as little as 1 gram per kilo per day all the way up to 2.5 grams per kilo per day in some subgroups. And the hypothesis that was posed by the question was it is better to give a higher protein dose to some critically ill patients, and that will improve their clinical outcomes. So the primary outcome that was looked at, as you see, is a higher protein dose. So I shouldn't say TPN, sorry, I should just say higher protein dose. Does that reduce time to discharge alive for the patient? And the secondary outcome was, does this higher protein dose affect the 60-day mortality figures for the patients? So as I said, this trial was conducted between November 2017 and December 2021. So part of that was during the COVID time, and that will factor in to the analysis and the discussion later on. It was an extremely large study. It looked at 85 intensive care units across 15 countries. I've listed the countries there that were involved in data collection. So it was international and had huge generalizability across diverse populations. It was registry based, which it makes mention of within the study. I understood this to mean that there is a voluntary data collection of what all the different ITUs were doing with regards to protein dosing, but that it was a voluntary kind of, this is what we're doing because there's no particular data available out there already to glean from. But that's what I understood by it, but I couldn't specifically see what registry based meant. The trial was single blinded, so patients were not aware of what they were being given and they were randomized, but because the clinicians needed to prescribe the protein and were involved in the administration as well, it was not possible to blind the clinicians, so it's single blinded. As I said, it was randomized and a computer generated randomized schedule was used, and then with regards to the patients, there were certain inclusion and exclusion criteria. So the inclusion criteria involved patients that were adults above the age of 18 who were within 96 hours of ITU admission and were expected to remain mechanically ventilated for 48 hours at least, and who had nutritional risk factors, so such as very high or very low BMI. And the exclusion criteria that they used were any patients that had already been mechanically ventilated or admitted for 96 hours, any patients that were deemed end of life or were not going to survive, patients that were pregnant, and patients that the clinician felt would need protein doses outside of what the study was looking at. There were also some centres that were, there were also some patients and centres that were excluded because the centres couldn't provide the higher dosing. So I thought that was actually quite interesting that some areas, and it's perhaps that's because they weren't included in the 15 countries, it might be that they were excluded at that point because there were certain changes made to this trial because of the time period it was conducted in. So the procedure is that there were two dose groups. There was a usual dose group which received 1.2 grams per kilo per day of protein, and a high dose group that received the larger 2.2 grams per kilo per day. And then this was calculated based on their requirements, and the energy was then minused off the total energy requirement, as Moira explained in her talk. And then that was how it was worked out. The targets were set using pre-ITU actual dry weight, and so patients that had a BMI of more than 30, the ideal body weight was based on a BMI of 25, and that was because they were trying to base it on, rather than just feeding fat, essentially, they were wanting to give protein dosing according to what the actual lean body weight was. The way that they achieved the protein targets was either enteral or parenteral nutrition, or protein supplements, and the clinicians were encouraged to achieve 80% of what was prescribed. This intervention was then carried out for 28 days until the patient died, or until they were transitioned fully to oral feeding. Patients who were then discharged from ICU and then readmitted would carry on the same previously assigned protein dose for that continuity. So the outcomes that they had within, as I've mentioned, the primary outcome of the EFFORT protein trial initially was to look at so they were looking at the outcomes the other way around, and then they had to revise the outcomes to time to discharge alive and 60-day mortality. And the reasons that I'll talk about a little bit further on in the presentation. But essentially, because of the time that they were conducting this particular trial, they found that the aim of the trial was to have about 4,000 patients enrolled. And by the time they got to sort of 2020, they realized they only had about 1,300. And that was substantially lower than what they were expecting. And it was mostly attributed to the effect of the COVID pandemic, which they expected to carry on. So then they had to revise this. The tertiary outcomes they looked at were hospital mortality, nutritional adequacy, and readmission to ICU. So the results, so as I said, 1,329 patients were fully enrolled, of which 32 were lost to follow up for various reasons. So the final take forward was 1,297, and the results showed that after randomization 60 days, the cumulative incidence of a live hospital discharge in the high dose group was 46.1% and the usual dose group was 50.2%. The 60-day mortality rate in the high dose group was 34.6% and the usual dose group 32.1%. And they found that the tertiary outcomes that they were looking at were similar in both groups for both. So within their interpretation, the conductors of the trial felt that giving higher protein doses to critically ill patients did not actually improve either of the outcomes, the time to discharge alive from hospital or the 60-day mortality. And it might actually, from the data they found, it might actually worsen outcomes, particularly for patients with acute kidney injury or a greater severity of illness. So the null findings that they found did not support the notion that mechanically ventilated patients who were fatter, older, more ill, more frail, so these are the sort of the high nutritional risk factors that they were looking at, or sarcopenic, would benefit from a higher protein dose, and actually that would be harmful because it was found that they experienced increased ureagenesis, and so patients with acute kidney injury coupled with increased impaired muscle protein synthesis and causing a higher metabolic burden would actually be detrimental for them. And so one of the recommendations of the trial was to not use high protein doses in patients with acute kidney injury and multiple organ failure. And I think that reflects what Moira said in her presentation of what the dose is in AKI. The main recommendation seems to be further research is required because there isn't a lot of data within this field, and also this trial was not as large as anticipated. They did, as on my previous page, they did recommend, and they felt that their results would be replicable worldwide, and that they felt that this would have an impact on how we conducted higher protein dosing, because it did show a difference, and it did show detrimental effects in higher doses in patients that were more susceptible. So the strengths of the study itself, so it addressed an issue where there isn't a lot of data, and that was seen to be quite, so it's a start. The generalizability, because it was a large multi-center international trial, there was a very diverse sample size and diverse population, but within the generalizability, whilst that's a good thing, that could also be argued that that is also a weakness of the trial, because it wasn't looking at a specific population, it was looking at everybody. The randomization, although it was so it was computer generated randomization, so it could be argued that that improved the results, and there was very minimal losses to follow-up, I think less than 1%, which is pretty good for a trial, and would increase the validity of the data. The weaknesses to do with this trial, I think mostly it could be argued that the trial was underpowered, particularly with regards to the 60-day mortality figures, because it aimed to enroll 4,000 patients. It enrolled 1,300, and they mostly blame that on the COVID pandemic related issues. So for that reason, they had to switch the outcome measures, which is not, I think if they were to conduct it again, would that affect the, or if they were to conduct any other, I haven't seen like that happen in a trial where they just switch the outcomes. I don't know whether that makes the trial more or less valid. They actually didn't measure further outcome measures particularly, and there wasn't a huge amount of analysis within the paper on them, although it's sort of like some of the tertiary measures would probably be of quite a lot of interest, particularly because there was in the trial, it does mention that they only looked at the two main outcomes, but actually higher protein dosing, maybe that would have an effect on patients' recovery and their mortality or morbidity further down the line, but past the 60 days. A lot was left up to the local ITUs in terms of the overall energy delivery. It wasn't dictated how much of the protein should make up of the energy delivery, so local ITU protocols were used, and maybe that's something that should have been more standardized. And of course it was single-blinded. If it was a double-blinded trial, that would increase its validity as well. A comment that was made within the paper was that patient selection didn't have enough of the higher risk subgroups, so patients that have trauma or burns or surgical groups that would in theory need the higher protein dosing. And is this possibly a COVID era effect, because less patients were being taken to theatre anecdotally, or is it more of so can you really draw conclusions about that particular subgroup for the higher protein dosing outcomes? So that was the trial that was performed, and then I looked briefly at the UHL practice and spoke to one of our dietitians just to see what we do in ITU here. And this is the guideline and the standard operating procedure that they have, and it actually does within it, it does say a lot of what Moira has said, and it does say if AKI present and no plan for hemofiltration, then a gram per kilogram per day of protein, which is the much lower dose. So that does tie in with what the trial found. But another thing the trial found was that the higher BMIs were being given high dose of protein, and actually that was detrimental for them. And as you can see, it's still recommended to give the higher BMIs high grams per kilo per day, and whether that needs to be revised on the back of trials like these, because if you're replacing high dose grams per kilo, the trial is saying that that's not the right thing to do, although further research is required. So does that need updating? I think I just wanted to finish off by saying that, speaking to the dietitian, Nikki, she said the landscape of dietetics within intensive care is changing extremely rapidly, because patients are changing, disease populations are progressing and developing, and everything is changing so rapidly that it's not always as clear cut. I thought I'd just put that in there as an actual sort of on the ground, boots on the ground approach. So that was my presentation. I can bring up the study for you if you want, but if there's any questions. And thank you for listening.
Thanks for doing that. And I was going to say how does it affect what we're going to do, but you kind of already said that.
Still going steak.
I don't know. Can't give patients steak on the unit. It's not okay.
Appreciate it.
Cool. Well, thanks for doing that. Much appreciated.